series. Today we have one topic, and this topic is intelligence of oral surgical procedure for beginners. Before going to start our webinar, I take the privilege to introduce our today's chairperson, our honorable speaker, as well as our panelist, and I myself. Today we have Professor Dr. Ruhul Amin sir, Head Department of Oral and Maxillofacial Surgery, Dhaka Medical College and Hospital. He also the President of Bangladesh Association of Oral and Maxillofacial Surgeons. And our today's honorable speaker, Dr. Subhashish Barman, Associate Professor, Oral and Maxillofacial Surgery Department, Dr. R. Ahmed Dental College and Bardhaman Dental College and Hospital, West Bengal, India. Today we have Dr. Mohammad Habibul Hassan Marshall, Assistant Professor, Oral and Maxillofacial Surgery, Dental Unit, Rajshahi Medical College, as a panelist. Today we have also Dr. Mir Nawaz Ali Rajiv, Assistant Professor, Oral and Maxillofacial Surgery Department, Bangabandhu Sheikh Mujib Medical University, Dr. Manjuri Mahmood, Assistant Professor, Oral and Maxillofacial Surgery Department, Chittagong Medical College and Hospital, Dr. Muhammad Aminul Islam, Associate Professor and Head of the Department, Oral and Maxillofacial Surgery, TMSS Medical College, Dental Unit. And today we have also Dr. Anupam Poddar, Associate Professor and Head, Periodontology and Oral Pathology Department, Dhaka Dental College, as a coordinator. And I myself will moderate this session. Before starting our presentation, I would like to invite our chairperson, Professor Dr. Mohammad Ruhul Amin sir, to say something. Sir, একটু unmute করে নিন স্যার।
Thank you, Dr. Uday Kumar Goswami. Assalamu alaikum and good evening, everyone. It is my pleasure to invite all of the oral and maxillofacial surgeons, dental surgeons, trainees, and students from home and abroad to attend the live webinar. Today, we have among us our speaker, eminent maxillofacial surgeon, Dr. Subhashish Barman, Associate Professor, Oral and Maxillofacial Surgery, Dr. R. Ahmed Dental College and Bardhaman Dental College and Hospital, West Bengal, India. Here we have our panelist, Dr. Muhammad Habibul Hassan Marshall, Assistant Professor and Head, Oral and Maxillofacial Surgery, Dental Unit, Rajshahi Medical College, Dr. Muhammad Rajul Islam, Assistant Professor, Oral and Maxillofacial Surgery, Dhaka Medical College Hospital, Dr. Mir Nawaz Ali Rajiv, Assistant Professor, Oral and Maxillofacial Surgery, BSMMU, Dr. Muhammad Amirul Islam, Associate Professor, Oral and Maxillofacial Surgery, TMS Medical College Dental Unit, and Dr. Manjuri Mahmood, Assistant Professor, OMS Dental Unit, Chittagong Medical College Dental Unit. Today our attention will be given on topics like intelligence of oral surgical procedure for beginners. The field of intelligence of oral surgical procedure for beginners has grown tremendously in the last decade, while the advances in like neural networking, natural language processing, image recognition, and speech recognition have transformed the field of oral surgical procedure in many ways. They have a number of drawbacks and challenges that are yet to be overcome. Now I would like to welcome our speaker to this live webinar.
Thank you, sir. Dr. Subhashish Barman sir, to present his presentation. I think it will be an excellent and exciting presentation. Dr. Subhashish Barman sir. Dr. Subhashish Barman sir, can you hear me? Dr. Subhashish Burman, can you hear me?
Can you hear me?
Yeah.
Hello.
Yeah. You are audible. Please
Yeah.
carry on, sir.
Can I start?
Okay.
Okay.
You can start.
Good evening, everyone. Though it is not evening, it is going to be night. We are already late, so no problem. I am very thankful to all the viewers, those who have joined today in this amidst COVID situation. And I am sincerely want to let my thanks to all these eminent persons present here, the chairperson, moderator, coordinator, and the panelists, doctors of panelists, because they are already known to me. I want to say a few words because when I was in Dhaka Dental College in 2015, I was invited as a guest surgeon, and that time these were present there. I can easily recognize them. I am really highly honored to see again their face, though it is a webinar, but still I can recognize all the faces there. And one thing is that I want to uh, in this COVID situation, I want to sincerely those who have lost their life in this COVID battle. I want to show that God really uh, peace, keep their soul in the peace. And now let's start with our topic, that is intelligence. Sorry. One minute. Sorry. So
Okay, it's okay.
it's okay. I think you can see the all this screen.
Okay. It's okay.
So first of all, I want to say a few words that oral surgery is a vast subject. It is not possible to cover up all the topics in the oral surgery, but I have picked up very few subjects of oral surgery, which is very interesting, as well as those who are present today as the viewers. I think in day-to-day practice, they will be get benefited if you listen it carefully. So first of all, it is a medical component in dental first line. Why medical patients component in practice is very important, because in day-to-day practice, we know that not that all patients was the normal patients, no medical problems. Yes, out of 10 or 15, 2 or 3 patients will definitely come to us with different medical problems like diabetes, one of the common medical problems, hypertension, another common problem present to us. But the problem is that when this type of patient comes to us, we are very confused what to do. Am I to treat this patient, or I have to send it to physician's consultation? And so this is the operator. So basically, if you know the basic points in case of when dealing the patients, the diabetic patient or hypertensive or any other medical compromised patient, I think you can easily treat that patient, or if necessary, definitely you can take the consultation, you can consult with the physician. So first I am going to hypertensive patient with hypertension. So let's think that a patient has come to me and or come to us with seeking the dental treatment. A dental extraction you have to do, acute pulpitis is there and you have to extract the tooth. But after measurement or after measurement of the blood pressure, you have seen that it is 170 by 100. So should I go for extraction, or should I send the patient to medical person for their advice? But I think if you just clearly note down that it is said, I am showing you the article journal point from where I have noted it, that it is clearly said if it is less than 180, the systolic pressure, and 110, the diastolic pressure is less than 110. That means 170, suppose a patient is having the pressure, hypertension is, blood pressure is 170, and its diastolic pressure is 105 or 104. In that case, definitely you can extract the two. There is no doubt that, but thing is that in that case, definitely you have to measure the blood pressure 3 consecutive times. And if you find that in 3 consecutive times the reading are same, then definitely there is no problem. You can simply extract the two. There is no problem at all. I am just clearing it. Thus, if there is no less than 120 by no problem, 120 by 80, but 140 by 90, no problem in any other surgical procedures. 140 by 90, but less than 160 by 100, no problem. But if it is 160 by 100, but less than 180 by 100, that I am talking about, in that case, definitely, intraoperative blood pressure you have to measure 3 consecutive times in normal condition. That means patient is restless, that will not, you should not count it. If patient is restless, if patient is under stressful condition, definitely that will give another value. So it is not that you should grant it. If the 10 minutes or 15 minutes gap, if you measure it and if it comes the same value, that is less than 180 by 110, there is no problem. And that you can see here, you can see that it is page 44, dental management of the medically compromised patient, written by Little and Fast, well-known book. Everyone reads it. So in that case, here it is written clearly. The page 44, it is written, if it is 180 by 110, you can simply extract that, no problem will be there. But what is the problem if it is above the 180 by 110? Problem is that in that case, or not only that, we already considered that yes, if it is more than 180, there is a chance of bleeding. It's not that. Not only bleeding, there is a chance of cardiac arrest too. It can happen in that patient. And so in that case, definitely you should be a little bit cautious about that. So it is another journal, that is Clinic Cosmetic Investigation Dent, published online 2016. It is clearly stated that if it is more than 180 by 110, you should not defer the elective treatment. You should not do any elective treatment or any dental treatment or any extraction or any surgical procedure. You should defer, or you should postpone, or you should take the medical advice. But if it is less than 180 by 110, no problem, you can simply extract the two. So it is clear now that 180 by 110, less than if it is 180 by 110, no problem will be there. Now we next come to the another problem, another major problem. I think most of this, those who are present here and all the dental surgeons, those who are dealing this diabetic patient, here you can see that what is the cutoff level, what is the cutoff point of the diabetes. We know diabetes is the endocrinological disorder where the problem is that during your insulin level, it falls. So the function of the insulin, it carries the glucose to the cell, it takes the glucose to the cell, and your energy is produced. So without glucose, energy is not produced. So it is very important that insulin has a major role for the level to decrease or increase the level of the blood sugar. So whenever the blood sugar going inside the cell, definitely the blood level, glucose level will fall. So that's why the insulin is a very important role in the control of the diabetes. So what is the cutoff point? So because we all know the patient has come to us again seeking dental treatment. Patient needs dental treatment, extraction, minor surgical procedures, any infection, whatever it may be. Patient is, suppose it is 175 is the your fasting blood glucose. Should I go for extraction or should I take the advice from the patient's physician? But it is clearly stated that in that medical compromised patient by Little Fellas, If the fasting blood glucose is below 200 milligram, no problem is there in any extraction of the tooth. It is not that you have to be well controlled. Well controlled means, most of the book it is written, the well controlled means it is the fasting blood sugar is within the 110. It is not possible always. And if your postprandial blood sugar level is 140. But if it is so that after taking all the medicines of the anti-diabetic agent, if it is not that controlled, what will do? Will not extract the tooth? It is not like that. It is simply stated that another journal of the Saudi Arabia in volume 32, issue 1, January 2000, in this year only, it has been stated. Here it has been stated that if it is below 180, you can extract the tooth. There will be no problem. But if it is above 200, there is a chance of infection will be more. And another problem is that it is said that diabetes is not only for the infection control. It is another problem is that in diabetes, the microangiopathy will be there. It is a disease of the blood vessels. So in that case, definitely we have to take care of that particular patient. If it is more than 200, we should advise of the physician. Unless and until it is not controlled, we should not extract tooth. We can come to the next slide. That is when the patient is another problem, big problem. Patient taking steroid. We know the steroid is a miracle drug. Sometimes it is a life-saving drug. Nowadays, so many our patients are taking for different reasons. It may be the autoimmune disorders. It may be due to the eye problems. It may be due to your our dental problems. Also use different type of steroids as a anti-inflammatory. There are so many diseases that there where the steroids are used. So there is one problem is that steroids, when are used from the outside, steroids is the drug that is secreted normally from our body. That is the supranatal glands. It is secreted, and the amount is secreted is 30 milligram. Regularly, it is secreted. And in the morning, it is 8 to 10 milligram. And that's why morning appointment is the best option for the patient, because it can control the stress of the patient. That's why morning appointment we should keep for that particular patient. Besides that, suppose a patient is taking 10 milligram of the prednisolone. So should I extract the tooth or should I go for steroid cover? That means steroid supplement. That means am I to give outside more steroids or not? So here in this slide, you can see the patient with the 10 milligram of the prednisolone, it is equivalent to beta-methasone 1.6 milligram, dexamethasone 1.6 milligram, hydrocortisone 40 milligram, methylprednisolone is 8 milligram. So this value is equivalent to 10 milligram. That means if a patient is taking 10 milligram of prednisolone, another patient is taking beta-methasone 1%, all are equivalent. So there is no problem. But if the patient comes to us and going to extract the tooth, you are intended to extract the tooth or going for any oral surgical procedures, what is your opinion? My opinion is that if it is 10 milligram, definitely steroid cover you have to start. What is steroid cover? That I will discuss in the next slide. But if it is less than 10 milligram, that is 5 milligram, no steroid cover is needed. Why it is not needed? Because it is said the steroid, which is when it is given from outside in the stressful condition, that it cannot produce the much steroid hormone to deal with that stressful situation. In that case, there is a chance of adrenal suppression, adrenal gland suppression, and that can cause typical hypotension. That is a fatal emergency situation may arise, and even patient may die due to the hypotension. So definitely we have to take care of that particular patient. That is very, very important. But previously it was said, when I was student, it was taught that steroid, if patient is taking 20 milligram of steroids for 2 weeks, for 2 years, you should go for the steroid supplement. But that concept has been totally changed nowadays. It is said The steroid, if the patient is taking before the 3 months of that particular day of your uh, treatment, if the patient has stopped taking steroids before 3 months, there is no need of any steroid supplement, because within the 3 months, the the gland, it can recover. That means this suppression will not take place. So if the patient is not taking the 3 months, within 3 months, there is, you have not to be worried about. If a patient is taking within the 3 months and patient is taking 10 milligram of the steroids, you have to go for steroid cover. The steroid cover is, usually we follow the Salemate protocol. That is very important. And here we can see that hypothalamus pituitary adrenal axis. We all know this axis is very important, because whenever the stressful situation arises, this hypothalamus secretes the corticotropin releasing hormone. It stimulates the pituitary gland secretes the ACTH, and it also secretes this adrenal, the supraadrenal glands, and therefore the cortex, the steroid is secreted. And it's the steroid, I have already told you, it is not only for the life-saving drugs, it has many other functions. That is the metabolism. It controls the metabolism, protein, carbohydrate, fat, and it is another important, that it acts as anti-inflammatory drugs. It is another important function is that it can deal with this stressful situation. So during the crisis period, when the stressful situation, because in the dental treatment it is a stressful event, and in that case, when it arises, if it doesn't secrete the amount that which is needed, then there is definitely problem will be that hypotension will be there and patient will die with hypotension. So in that case, you have to definitely take care of that particular patient. So how we can deal? So we can categorize it mild, moderate, and major. So mild is, suppose you are going to extract a tooth, it is called a mild risk. So there is no risk at all. If the patient is 5 milligram of penicillin, I have already told you there is no need of any supplement. But if the patient is 10 milligram, in case of mild risk category, definitely you have to go for steroid cover. But if it is moderate to major risk category, that means any infection, multiple extraction, any cyst operation, or any osteotomy, cancer surgery, whatever it may be, it is called major risk factor is there. In that case, steroid cover will be increased. That means steroids, dose of the steroids to be increased. What is that? You can see the Salemate all. Here is the minor. You can ignore this inguinal hernia repair, because it is only, suppose it is only tooth extraction. Here you have to give the usual corticosteroid dose. Suppose patient is taking 10 milligram, you have to give 10 milligram along with the 20 milligram hydrocortisone injection. That is all. So it is 25 milligram hydrocortisone injection you have to give just 1 hour before any oral surgical procedure. It is moderate. That means you are going for any impacted surgery, you are going for any multiple tooth extraction, any cyst operation. It is usual corticosteroid dose. Another is 15 to 75 milligram of your hydrocortisone for 24 to 40 hours. You have to continue. But in case of major, where there is a maximum amount of the steroid is needed due to your stressful situation, here it is that usual corticosteroid dose to be continued along with 100 to 150 milligram of the intravenous hydrocortisone. You have to continue it for every 8 hours for 48 to 70 hours. But that means for another 3 hours, every 8 hours you have to continue. That is the Salemate et al. You have to follow. Not everyone should follow it, and it is worldwide. It is accepted, and most of the country it follows this rule of the Salemate all. Next slide is that whenever the patient with pregnant patient comes to us, that is another problem. Even I face also. I don't know what about the viewers, your opinion, but I think whenever the pregnant patient, usually what we do, patient with the acute pain, that is a problem, because most of the drug is contraindicated. You cannot even go give the NSAID or the painkiller. You cannot go for any X-ray because it is also contraindicated. What will you do? So the major problem in case of pregnant patient is that pregnant patient, the physiological changes are maximum. What are all the all the systems are changed. That means respiratory system, cardiovascular system, your hematological system, your renal system, your endocrinal system, everything is changed. It is changed according to the growth of the fetus. It is changed according to for the delivery, so that the mother it is developed accordingly, so that it can bear that fetus for the purpose of bearing that fetus. It is all the physiological changes are occurred in the body. So accordingly, the hormone secretion is there, which is maximum in some cases. And so patient with different problem comes to us. That is eclampsia. Patient has come to us with a hypertension. So basically, whenever the patient with pregnant patient comes to us, you have to first of all you have to check all the vital signs. We all know the vital signs. You have to definitely check. And what are the other things you have to check? You have to check the pressure, high pressure, because if it is high pressure due to the eclampsia or due to other reasons, fluid retention, you have to consult with the gynecologist or the physician as well. And another thing is that one of the major problems in the third world country like Bangladesh, Bharat, India, and Pakistan, whatever is the anemia. Anemia is very, very fatal situation. Even I have seen in our hospital, patient has come to us with only the 5 gram of the blood hemoglobin level. And so it is very difficult to deal with that patient. Even you cannot do any even simple extraction also. So unless until if you just supplement with the blood, and then you can carry on. So what you will do in case, you have to know what are the drugs that you can give to the patient. That is very, very important. Food and Drug Association, they have categorized for the pregnant patient according to A, B, C, D. And you have to always follow the drug. That means your antibiotics, your NSAID, whatever you choose, you have to follow these guidelines. But sometimes we don't follow it, and then the problem may arise anytime. So I think everyone should follow these guidelines that has been considered throughout the world. So you see, this is the antibiotics during pregnancy. That is, first you have to know that under the FDA category, there is no drug, very few drugs are there under category A. Only is that some vitamins there and the levothyroxine, that is the thyroxine hormone, that is the under category of FDA category. But all others, that is, if they are under the B. C is not safe. D is the steatogenic effect is maximum. So we always stick with that penicillin, cephalosporin, carbapenems, this drug clindamycin, azithromycin, which is more or less safe to the pregnant patient. You can safely prescribe if you think that this antibiotic is very needed or it is essential for that particular pregnant mother. And these are the NSAID drugs. NSAID, I have already told you, it is totally contraindicated. But acetaminophen or the paracetamol, you can safely prescribe. It is under category evidence rating. You can see it is under B. But other non-steroidal, it is C. You cannot prescribe. Histamine H2 blockers like your diphenhydramine, your chlorpheniramine, you can safely prescribe to the patient. But the problem is that what I have faced in my personal chamber or in day-to-day practice is that if suppose patient has come to you with the dental pain, acute dental pain, you know that I cannot, because it is said that second time study is the safe zone. But if the patient is third time, so what will you do? Either you send the patient for gynecologist consultation, or the patient will go door to door of the dentist. There is no value, because pain, if you cannot control by any means, there is no way the patient you can control it only by the paracetamol. I think so, because it is my personal bitter experience. I have faced this in my personal chamber or this clinic or hospital, whatever you say. It is the patient. So what will you do? There are so many journal articles there, that is Journal Dental Anesthesia Pain Medicine. It is published online, and there are so other drugs. It is not possible to maintain all the name of this article. This space are very, very less. So it is clearly mentioned there is no such contraindication that you cannot go for any uh, anesthetic, local anesthesia. Safe local anesthetics, which is very commonly used, it is the lignocaine, definitely. Lignocaine you can safely use if it is emergency arises. But if you think after taking the acetaminophen, the pain has been controlled, no problem is there. But if after that severe pain is there and patient is going to door, in that definitely you have to take the serious measures you have to take. What you will do, you have to go for simple pulp extirpation under the lignocaine. But in the first trimester, because there is organogenesis is totally going on, and in the last stage, there is a chance of the stillbirth or this still baby, and that's why if in that case the patient comes to you, you can simply use the lignocaine, but you have to remember it should not cross the maximum limit of this lignocaine. So under this, within 10 to 15 minutes, because the lignocaine action will be there only for 10 to 15 minutes. So within 10 to 15 minutes, I think you can easily open the chamber and you can go for the pain control. Because whenever you open the chamber, whenever the exudate will be relieved, the patient pain will go up and definitely the patient will give you rehab or patient will give you, definitely this is a good doctor to me. So I think that is the best thing that we can do for the pregnant patient. Next is that so next is that I don't know because all these practicing doctors, the eminent doctors are present here. So if you just see the 10 or 15 patients regularly, out of 2 or 10 or 15 days, out of 2 or 3, you will see that patient has come to you that I am taking clopidogrel or any antiplatelet drugs like aspirin. That is a very common. So there is so many dilemma. I can give you one incident that when I was in RG Medical College, I have to remember one call book was given to me from the principal that one patient has been admitted in the ICU, please come. So whenever I went to that ICU department, I saw that one dental surgeon, he has stopped this aspirin drug for this patient, and within 7 days, this patient again this MI attack has been precipitated. So there are so many articles, journals are there, and it is said that thrombotic episode may occur anytime if you stop it within 7 days. And it is clearly mentioned, so many journals are there. It is clearly mentioned, no problem is there. If you simply automatically extract the tooth, even patient is taking aspirin, clopidogrel, and the both. Nowadays, the cardiologists, they prefer the aspirin and clopidogrel both because it can control this thrombus formation more than aspirin alone. So that's why it is clearly, if you just simply extract the tooth and if you just put some this topical hemostatic. What is those topical hemostatic? One is passive or mechanical agents. You can see the name of this passive or mechanical. We all this follow this. Gelatin, I usually use gelatin gel foam, name of gel foam. It is available everywhere in the world. Collagen you can use, cellulose-based products you can use. These are your commercial name. So you can use anything. So what is the purpose of passive? It has no role, active role. It just create a mechanical pressure over that clot, and so that clot formation it will be not dislodged. So it is my personal experience. I have seen so many cases after giving this gelatin foam or this collagen or this drug, there is no bleeding at all. Even I don't stop ecosprin or clopidogrel, whatever it may be. So I can, it is the American Journal of Cardiology, published online July 23, 2011. It is clearly mentioned, even the patient is taking 2 drugs in the combination, you should not stop it. You can simply extract the tooth, you can just put this hemostatic agent and you simply suture it. There is no problem at all. Maybe out of 10 to 15 cases, one minor oozing may be there, but that is minor and that problem you can easily manage. So these are the drugs that is very, very important. But what about the patient when the patient is taking warfarin or the pomegranate drugs, which is called anticoagulant? When the patient is taking warfarin drugs, it is 5 or 10, whatever according to the patient condition, it is the dose is calculated by the cardiologist. I am not going in that. So when the patient is taking 5 gram or 5 milligram or 10 milligram, or when the problem is that in that case also there is no problem. But problem is you have to check the PT. We all know. For thrombin time you have to check, because the 2, 7, 9, 10, this 4 drugs, it is this, it is a vitamin K, it is produced. This 4 your blood factors, blood clotting factors, it is controlled by this vitamin K. So whenever the patient is taking this drug, this prothrombin is not synthesized properly. So bleeding will be there, and you have to check the value. If it is, most of the book it is written within 3.5, but I think you should be consider the maximum 2 to 2.5. 2 to 2.5 is the maximum to me, and I cannot say that you have to constrict on that only 2 to 2.5, but most of the book is written 3.5. I think sometimes 3.5, if it is the iron value is 3.5, there is a chance of bleeding. So you should stick with this 2 to 2.5, and there will be no problem at all. So these are all about this your warfarin, is antiplatelet and anticoagulant. I think that will definitely give you the proper indication. So now the patient with the angina and myocardial infarction, with the nowadays the patient, most of the patient above 60, they are under the stressful condition. Most of them, they are live the sedentary life. They have usually they don't usually they under the stressful situation, the angina may be precipitated, and myocardial infarction. It is another problem. It is not only for the aged people. It is another problem for the younger adult also. So in that case, what will do? If the patient or the angina comes to us, what will do? And if the patient with myocardial infarction, post-myocardial infarction, what will you do? In the angina patient, definitely, if you have to take the forward history, and you have to take the anxiety reduction protocol, you have to strictly follow. First of all, second is maximum stress you have to control by the anxiety reduction protocol, or your reassurance. Assurance is the you have to give to the patient. Third one is that you have to ask the patient whether you have bought this the nitroglycerin or isosorbide dinitrate in your pocket or not, because most of the patient I have seen, the patient have already told me that I am taking this isosorbide dinitrate or sorbitate, whatever it may be, and they usually before extraction they usually take sublingually. So that is a good thing. So definitely, but for your safety, you should ask the patient whether you are carrying it or not. So, and that your oxygen you have to always, if necessary, you have to always keep before any extraction, because that is another problem. Oxygen supply sometimes it gets low. So angina patient, you have to just in this way you can control. But the problem is the myocardial infarction. You can see this is the angina patient where this the blood vessels is narrowed, and this oxygen supply is totally less, and that's why there will be suddenly there will be severe pain in the chest, and it can radiate to the left side of the hand. And that is another sign of the angina. The myocardial infarction, whenever the patient of myocardial infarction, post-infarction comes to us, you have to take the proper history when the first attack was occurred. If it is within the 2 months, don't go for any dental treatment, because it has been seen after 3 to 6 months this scar formation takes place in the necrotic area. Another thing is that your collateral circulation develops in that area particularly. So 3 to 6 months is definitely a good time for the dental treatment, but definitely you should take the consultation from the patient's cardiologist or any other physician. So if the patient they suggests that yes, no problem is there, definitely you can extract the tooth, there will be no problem. But as because patient is taking antiplatelet, anticoagulant, different type of drug, you have to always notice all these drugs, and I have already told you how to take care if the patient is taking antiplatelet and anticoagulant. So now it is that patient with the liver and kidney disease. Now, alcoholic fatty liver, we all know it is a dangerous disease. The patient in your non-alcoholic fatty liver is another problem, and there are hepatitis or the jaundice is another problem to the dentist. So what will do? What are the antibiotics you have to prescribe for this liver disease? You can see the antibiotics safe in liver disease are penicillin, amoxicillin is clavulanic acid. These are sole antibiotics that is definitely it is helpful. Clindamycin, it is also safe. Clarithromycin, it is also safe. Metronidazole is the normal dose. If the liver disease is mild, you can prescribe metronidazole. Doxycycline normal dose is safe. Vancomycin normal dose is safe. So these are the drugs which you can safely prescribe if the patient is having any liver problems. But if you think that is your liver damage is maximum, don't go for any extra stress, give any extra stress to the patient, simply consult with the physician. Now it is your chronic, your renal problem. We all know renal kidneys have many functions. First function is maintain the acid balance. It has the endocrinological function, that means it produces renin. It has function of the hemopoietic system. It produces erythropoietin. That means when the patient is end-stage renal disease, patient usually suffers from anemia. So in that case, in the kidney disease, end-stage renal disease, definitely it is one of the biggest problem or challenge to the dentist or the dental surgeon. So what are the safe antibiotics that you can prescribe? Here you can see cloxacillin, erythromycin, ketoconazole, rifampicin. These are the safe, at most safe. Fairly safe is that doses should be you can control if necessary. That is ampicillin, amoxicillin, clindamycin, and metronidazole. You can, but if you think you can control the drug. Another is that your other drugs that you should not test because it is unsafe for this chronic renal disease. So this is all about the liver and kidney disease. Now we have more or less, I have already told you, the compromised medical problems are many. So it is not possible to discuss all these diseases in this short time. But I think this few, what I have described, I think it will be definitely helpful for the beginners. And now I will come to complications. So after tooth extraction, your complications definitely arise. If any dental surgeon or any dentist says that I have no problem, I don't believe. Even after 25 years of practice, even I have also problem. Pain patient comes to us with the bleeding, patient comes to us with swelling, patient comes to us with pain. So many problems may arise, but it is mandatory. It has to be happened. So patient usually complications it is seen, it is the bleeding. I think the main problem patient comes to us with the bleeding. How will you manage? I think the bleeding problem, whenever that is, we all know that it is primary bleeding. It is a reactionary bleeding, primary bleeding within when you are doing the extraction. Even if bleeding starts, that is primary. So there are so many causes are there. I am not going in details of that. If it's a reactionary, it is most is that patient the dislodgement of the clot. Another thing is that your blood pressure if it suddenly rises due to the patient stress, it can also cause this reactionary within the 24 hours. The reactionary hemorrhage is within the 24 hours. If the patient comes within 24, that means you have to think that it is the reactionary hemorrhage, and it is very easy to treat. First, you have to treat the patient, you have to remove the clot and see whether the bleeding is from the soft tissue or the hard tissue. If the hard tissue, it is there, you have to find that bleeding is from the bone or the laceration. So then definitely You simply put all that. I have already told you that mechanical, this topical hemostatic, and you simply suture it, and that is all about this controlling the hemorrhage if it is that. But if it is a soft tissue, just simply suture and your pressure pack is sufficient to control the soft tissue hemorrhage. Now is hematoma. We all know hematoma is the collection of the blood in the tissue space. It is nothing you can do. Main thing is that it can be due to the when you accidentally if you touch the or the if you injure the blood vessels. If during accidentally if there is trauma, and if you go for tight suturing, it is another problem. If you go for tight suturing, that cannot escape from that socket and it will accumulate in that tissue space and it can cause the hematoma. Next day, patient will come to the huge swelling. Sometimes patient gets afraid. What is happening? Previous years or the few months back, I also extended, but it was not happened. Why it is happening? Will happen. But definitely, you have to assure the patient it is a hematoma. It is nothing to be worried. Simply, you go for your cold compress for 24 hours. That is sufficient because it will control the bleeding due to the vasoconstriction. But after 24, the role of the cold compression is not there. It is that you have to go for hot compression. It has two functions. One is that it will thus increase the blood flow due to the vasodilatation. Another thing is that if you prescribe antibiotics, you easily reach to that area. That is the function of that hot compress after 24 hours. So I think within the 2 to 3 days, the hematoma will be controlled. But sometimes we get confused whether it is hematoma, it is due to that problem that I already described, or it is due to the infection. So if it is infection, you will easily notice that it is a red area over that swelling. The patient is having systemic malaise, fever, and the typical pain, throbbing pain will be there. So definitely you can distinguish the hematoma and the infection. Next is the trismus. Trismus, I usually when I teach my students, trismus is the frequently asked question to by the patient. Why I cannot open the mouth after extraction? Why the previously I extracted the tooth, it was not happened? Why it has happened? So it is cancer or it is something else. It cannot be cured. So all these questions definitely come. You have to answer. Nothing doing. So trismus, whenever the patient comes, what I do. It is my tips to all the beginners. Before any your inferior alveolar nerve block, I ask the patient only for inferior alveolar nerve. After giving an inferior alveolar nerve block, I ask the patient, I tell the patient, thus you go for exercise, active jaw exercise, open and close, going back to home. Not after when it will happen, this trismus. Just from the day beginning, after extraction, you start this active jaw exercise, opening and closing. I think it will never happen. Trismus will never happen. I am sure, 100% sure. But if it happens, what we will do? After 2 days or 3 days, this patient suddenly comes to you that I cannot open the mouth. Whenever I try to open it, is severe pain is there. What will do? Definitely, you have to ask the patient that you have to go for active jaw exercise, though it will pain, because you have to know trismus pain. It is the body's own your defensive mechanism, because whenever you will close the mouth due to pain, there will be less inflammation. So less pain will be there. So it is body's own defense mechanism. It will not allow you to open the mouth. But if you do it like that, you cannot open the mouth. And after 10 days or 15 days, patient will come to you with the severe fibrosis. And that time only option is that either you have to go for passive with your screw, or you have to go for the myotomy. That is a very big problem or big operation, or that's not a minor operation. So I think that's what I have told you about the trismus. If you simply follow, I think it is easily, you can manage this case of trismus. Next is the displacement of tooth. The displacement of tooth it usually occurs in case of wisdom tooth removal. I have seen my one professor or my colleague, once simply it was slipped down in the lingual pouch, and it was very difficult. It was not at the actually lingual pouch. It goes down to your submandibular fossa. So after doing extraction, we can locate, but because it is not possible to manage it intraorally, so definitely it was operated and it was taken out by under the GA, general surgery, general anesthesia, sorry. So that is the method. So if the displacement tooth occurs in your lingual pouch, you simply try to find out intraorally during extraction whether you can locate it with the help of index finger or not. If you locate it, just to raise the flap of the lingual flap and simply try to elevate it with the help of the index finger. If you are failed to do that, definitely your option is go for the any X-ray and try to locate it and go for your further treatment. That is, but the question is that displacement tube, if it is happens in case of your antrum, maxillary antrum, it suddenly perforates and it goes inside the antrum, what will it do? It is another problem. So if the tooth is there, definitely we all know cardiac loop operation is the best choice. But if root is there are two options is there. One is that you simply take a long gauze, definitely sterile gauze, and you pack it inside this through this hole in the antrum, and suddenly you just pull it. If the root is there, it can come out. Another thing is that use that high section your machine, and you simply put the nozzle of this high section inside the antrum. And if it is root is there, I have seen one or two cases where that root has come out. So this is all about this displacement of the tooth. It can happen in upper, it can be happen, but most of the cases I have seen in the lower, in the lingual pouch or submandibular pouch. Another thing is the orodental communication. Orodental communication we will all know, but I want to discuss few things. Whenever orodental communication is that we always try, we leave the patient and we try to locate it, whether orodental communication has been developed or not, but don't do it. I am telling you, no, don't do it. But if you do it, unnecessarily the problem will create it. Because if you go for your curating or if you probing, there is a chance of dislodgement of the clot. I am telling you, if it is 2 millimeter only, there is no need of any your treatment. Simply blood clot will be there and it will be healed up. If it is 2 to 4 millimeter is there, just to if you give a cotton pack over there and the blood clot will be over there and it will gradually be healed up by secondary intention. But if it is 5 millimeter, definitely the problem is there and definitely you have to go for the surgery, that is buccal and palatal. So whatever you choose, this is our buccal. Nowadays it is I prefer this buccal but a fat grafting. And it is a very quickly it is healed up and it is a very good choice to me. So, but how do you know if you don't go for any test that is nasal blow test, fork test, if you don't do how do you know that it is the communication has been developed? So whenever you extract the tooth, you look at the apical portion of the root and you have to see whether any bone is there or not. If bone is there, definitely you have to think it is more than 2 millimeter or 4 millimeter. There is no other choice. You have to go for surgery, buccal flat. But if it is only simply the tooth has come out, don't worry. It is simply within the 2 to 3 millimeter only, and you have to not to be just go for that. You allow the blood coagulation, and you will find that after 10 to 15 it will be totally held up. That is the thing of the orodental communication. But don't go for any probing initially if you find that there's orodental communication has been developed. Otherwise, there is fistula will develop, and that is a problem. By patient, I know many cases where the patient was definitely annoyed of this problem because they think that orodental communication is a big problem. It is not a job of a dental surgeon. It is job of the plastic surgeons or someone else. So they are really annoyed of this fact why it has been happening. But whatever it may be, we should not do it. Now is the maxillary tuberosity factor. Another problem. I have seen so many cases. I have seen my students. I have seen even in when I was starting my practice as a beginner, maxillary tuberosity is very common. Only the 8. Upper 8, if you go for extraction, you will find that suddenly the chunk of blood, the bone has come out with the tooth. And if you pull it, all the tissue, that the palatal flap or the buccal flap, it will come out, and there will be huge bleeding because venous process is there, and there is a chance of your accidental olo-under combination development. So this problem will be there. So what will you do? You have two options left. Either if you find that there is resistance during your pulling of the tooth, you simply don't pull it. You just place it in that exact place and you suture it, your soft tissue, or you just wearing it with the next tooth and wait for 3 to 4 months. When the total healing will be there, you plan it, you just raise the flap, you go for your sectioning of the tooth, and you can easily remove without any complication. But if you want to remove it in that day only, then definitely if you find any resistance, you have to raise the flap, you have to go for the sectioning of the tooth, but there will be always chance of your laceration of the tissue, the damage will be there. So that you have to accept. Otherwise, I think it is the best policy, and you have to always inform the patient that it has been happened and it is not the problem at all. After 2 or 3 months, I will do again this, I will remove the tooth. That you have to reconfirm the patient again and again. So this is all about this maxillary tuberous nerve damage. I will come later on. So it is you can see 1 patient of the hematoma, 1 patient of the dry socket. Dry socket I will come, and this is the trismus. Patient cannot open the mouth, we all know. This is the post-extraction swelling of the cheek. This is the bruising. It is that under the skin when it is called bruising, and it is another problem. Patient is always frightened. What is happened? I don't know. Before it was not happened. In that case, you have to say that this blood clot, it is under the skin. It will go off within the 7 or 10 days. Nothing to be worried about. This reassurance is sufficient for this step up. No medicine is needed for this patient. This is the case of dry socket. Dry socket is another problem. I think that most of the practitioners, they usually, after extraction of the lower mainly, dry socket is very, very common pain, which is very common. And sometimes, not the zinc oxide regional, what we prescribe usually in case of dry socket, you have to change every alternate day. Means I have seen 2 or 3 cases where I have to change the your zinc oxide regional 5 to 6 times. It took another 10 to 15 days to control the pain in case of dry socket. So that will be there. But zinc oxide regional and nowadays albuterol is the best thing. But what I do usually in case of your extraction after removal of the your third molar, where the dry socket is very common, I usually after extraction I put the albuterol in that day only, and I think that very rarely the patient has come to is the problem of the dry socket, because albuterol is definitely a good role, and definitely you have to prescribe the anaerobic to control the anaerobic infection, metronidazole or any imidazole group of drugs that you have to definitely prescribe. So now this is the case of angioneuritic edema. This was the allergic manifestation after taking the penicillin. I am not going in details of the allergic manifestation because it is a very big topic. So, but the one thing I want to describe, there is a problem is that I have seen that whenever the patient, we are giving that, suppose the patient is cellulitis is there and we want to give the patient that intravenous penicillin. So in that case, I have seen most of the doctors, even the patient in that your medicine shop, they usually test only in the single hand. That is the major blunder they usually do. Because there are 2 things that you have to do. That one is sensitive, one is challenging dose. Sensitive dose and challenging dose you have to always follow. What is sensitive dose? Sensitive dose means that when you are testing it, that this penicillin group of drugs with this forearm we usually test it. So after your sensitive dose, if you find that there is no problem, there is no your swelling is there, that doesn't mean that the allergic manifestation will be not there. So what you have to do, again, you have to do it for the challenging dose in another hand, the forearm. You have to again go for another test. So in that case, if it is negative, that means there is no swelling, no whale is there. That means there is no problem. The patient will allergic reaction will be not there. Even I have seen many doctors, they usually are afraid of using the lignocaine and they test it again and again for uh, for the allergic manifestation. But if you check it in the forearm, after that again you have to check it internally also. If you don't want to check it in another hand, just if suppose you have checked it the lignocaine in one hand, only 0.1 millimeter. Again, you have to for the challenging dose, you have to check it in that 0.1 cc in your intraorally. If there is no problem, there is no allergic manifestation or whealing or is not there, that means you can safely use that medicine. That is, I want to say, because it is a very good thing of this challenging and the sensitive dose. This is the abdominal thrust helmic procedure. We all know. I am showing you because tooth or any your endodontic instruments, it can go anytime. It is a definitely emergency procedure, and we have to prepare for that. So if the patient is conscious, you have to go back of the patient and you simply keep your one hand just the fist in just below the your umbilicus, and you just give the inward and upward thrust like that. Next picture, and you can, it will give the your intra-abdominal pressure will be increased, and it will help to you remove that foreign body from that person. But if the patient is unconscious, you cannot keep the patient stand. Then in that case, you have to put the patient in the lying down position in the floor, and it's the same procedure you have to follow, what you can see in that picture. So this is a picture of the radiograph showing displacement of the tooth root. You can see this is a displacement of the tooth root in the maxillary sinus. Your radiograph showing in the lingual pouch, accidentally, it, as I said, is not clear at all. And the tuberosity fracture, it is very common. I have already told you. So those you have to follow it. And this is the mandibular fracture. This is very common when you are extracting tooth. If unnecessary is maximum force is given during extraction of your mandibular third molar tooth. In that case, there's a chance of breakage of this mandible, and it has been happened here. There's a total in the angle of the mandible, there is a breakage, and it was repaired by afterwards by the oral and maxillofacial. But if you just follow some basic rules of the impaction that I definitely I will discuss, I think you can avoid this situation. So now we come to the lower third molar impaction. We all know what is impaction. I am not going, it is written here. It is the American Society of Oral Surgery in 1971. It has been, this definition has been given. But I want to show you a few things. It is all known, we all know, but why I am discussing it, when the next slide will come, it will definitely help you to understand the basic facts. I am talking about the beginners, because this will definitely help you to get some idea from this radiograph. That's why I'm showing you. We all know index classification is all what is index classification. It is that your relationship with the second molar or with the third molar. Accordingly, it may be mesoangular, vertical. There is other classic. This two angular maybe there may be vertical. There may be mesoangular. There may be horizontal. Whatever it may be, you have to classify it. Now it is Pale and Gregory class. This is also important because you have to know it. Because whenever we go for any impact, I have seen that my students or some other doctors, they usually see the first, they read that, they don't read that carefully the radiograph. They only see whether it is mesoangular. Yes, it is very easy. They only see the distal angular, it is difficult, but I can do it. So they started doing it, and the problem definitely will arise. It is not like that. Some basic things are there that if you certainly follow it, I think in impaction is very, very easy. And if you can do it without any complication, without any problem of this particular patient. So it is class 1 position 1, where you can see position is that level is position A. Class 1 means there is maximum pace is there between this your ascending ramus, and that it can accommodate easily. Class 2, there's that your this mesiodistal width is not sufficient to accommodate in that pace. Class 3, it is most of the part it is within this your ascending ramus. That is a difficult problem. There is one is a class 3 problem is very difficult because is this bone, it is a very hard bone is there, and you have to sacrifice maximum bone. So lots of time it will kill, and problem will be there post-operatively. That is a different thing. But I think you should know what is class 1, what is position A. That you have to know according from the classification. Now I am telling you this. So just your right side. I am talking about the right side. What are the things that you have to definitely think from this radiograph? One by one is that I have already told you this Winter's classification. You can know it is you can see it is horizontal. Why? Because if you draw a line in the longest tooth, it is vertical. So it is horizontal. So it is clearly horizontal. This is the first thing that now you are clear it is horizontal. Now it is clear its position and your class. Position it is position B, and class it is class 2, because the space is very short. So it is all about the Spell and Gregory classification. Now is that you have to think this relationship between the mandibular canal. That is very, very important. I am coming in the next slide. What is the relationship between the mandibular canal and the mandibular tooth? But you can see this radio opaque area, this where this mandibular nerve is going. What are the relationships with mandibular canal? You have to minutely find out. Otherwise, after extraction, if the patient comes to you with that, there is a paresthesia, my lip I cannot move. Whenever I am saving my beard, there is a problem. I am not getting any sense. All this problem you have to face because I have not noticed that this relationship between the mandibular canal and the tooth. So you have to definitely. Next is your canal, your basal lamina, this bone. The space between your dental bone, this is very, very important. Whenever this basal bone, it is in the patient above 60 years, or where the space is very narrow, that means sclerosis has been already started, and in that case you have to remove, and the bone is very hard, you have to give maximum time for removal of that bone. But in case younger patient, it is not like that. Another thing is that root portion, your curvature of the root. If the root curvature is distally present, it is favorable. But it is visually present. Whenever you are lifting the tooth, that will be problem of will be there. Another thing is that in that case, one basic thing is that you have to decide whether you go for decapitation or simply you will elevate the tooth with the help of elevator. How will you know that? The basic fact is that just you draw a line. So if you make it straight. So this is your mesial, this is your distal. This is clear. This is your mesial, this is your distal. So if you just make it straight, so from the mesial portion, you draw a line, imaginary line to your distal root, imaginary line to your distal root. And if you make an arc, if you make an imaginary line and you try to rotate, you find it will cut this 7. So if this line cuts this 7, definitely you have to go for decapitation. That means sectioning of the tooth is mandatory. You have to do that. Otherwise, you cannot remove that tooth unnecessarily, you will be in the trouble. That is the basic thing when you are going for extraction of this type of tooth, where the degree of impaction you can assess from this tooth, how much bone to be removed and what are the problems we can face. So by simply calculating it, you can easily go for either you have to go for sectioning or the only elevator. So accordingly, you can charge the patient you can charge your money from the patient. So this is all about now I will come to this one important thing is that relationship of the mandibular canal. So what is that relationship of the mandibular canal? I have already told you. This is the radio effect shadow. You can see that this very narrow channel by which the mandibular nerve is passing through. So here there is 5 your radiograph presentation. One is that there is continuation. A and B, you can see there is continuation of the line. Though it is, you can easily see that it has touched this radiograph, but it is not that. Continuation means either it is buccally present or distally present. If you not damage during extraction, this unnecessary, if you not damage, there is no chance of injuring this mandibular canal. So whenever there is continuation of this canal is there, you can sure that your problem is less. But other thing you can see that the C, D, and E, you can see in all that case that there is a discontinuation of the mandibular. And in that case, definitely you have to be very, very cautious during extraction of the mandibular tooth or this impacted tooth. Otherwise, you will be in the problem. You will land up in the problem. So in that case, here, if you accidentally, unnecessary, without looking this radiograph, if you just go for extraction, definitely problem will happen. Patient will come to you with the paralysis. And one thing is that there is 3 things have been done. One is neuropaxia. That is simple, your nerve trauma. There's no problem. It will automatically, it will be all right within 7 to 8 days or 10 days or 15 days. If it is axonomatosis, there is continuation is there, but there is maximum injury, but the continuation of the nerve is there. It will take 3 to 4 months. But this 3 to 4 months, you have to fight with the patient. Why this is happening? Why this paresthesia has been developed? Because I have not looked this X-ray carefully. But if it is neurometastasis, that means the action has been totally cut off. There is no continuation. There will be no chance of recovery. There is a permanent damage, and this patient will have permanent your paresthesia forever. So otherwise you have to go for micro your neural your anastomosis. That you can do that. That is another thing. I am not going up there. That is a surgical procedure. But if you look all these things carefully, I think you can definitely save from this type of hazards. So this is one tooth we have done in our the simple case. You can sectioning of the tooth has been developed. You can see that we have raised the flap. We have cut with all we know all these things, and we have sectioning the tooth because sectioning of the tooth has been done because you can see that if you draw a line from the mesial to the distal root, you can see that it is cutting the 7. So that's why we have sectioning. We have sectioned the tooth, and this is mandatory. You have to do it. Otherwise, you cannot lift the tooth from the socket. So these are the complications of the pain, hemorrhage, trismus, dry socket. I have already discussed more or less. And inferior alveolar nerve, I have already told you. If it is neurometastasis, there is no chance of recovery. Otherwise, within 3 or 4 months or 6 months. And there is, and one thing I am telling you, sometimes if the patient complains to you that after 2 or 3 months there is no development at all of the paresthesia, simply along with this vitamin B complex, nowadays it is you can use this very low dose steroid for 8 to 10 days, but gradually you have to taper the dose. And I have seen the few cases there is maximum rapid development or the paresthesia, improvement of the paresthesia. So you can safely prescribe for the few days if the patient is not having this blood sugar or other hypertension problems. This I have already shown you. So this is another problem, dislocation of TMJ. When the maximum force is given during extraction of the tooth, this can occur. And what happens? This articular eminence comes anteriorly. This is the radical eminence. It comes anteriorly. A patient cannot close his mouth. The problem is that you have to reduce it immediately. And if you don't know reduce it, and if it is more than 10 days or 15 days, there will be the spasm of the lateral pterygoid muscles, and it is very difficult to treat that of patient unless and until if you go for general anesthesia under you have to go for the general anesthesia. You cannot reduce it. So initially, if the problem is there and accidentally there is this type of things happens, you can easily just you put your two thumbs over that last tooth or the your molar first molar, and you just give the pressure downward, upward, and backward, and simply you can place that your condyle in the your original position. So now I'm talking about the space infection, one of the most interesting thing I think so. Because space infection is the common. Whenever I am talking about why is this common, because space infection, if these are the primary maxillary spaces, canine space, buccal space, infratemporal space, all this space we all know. But if in this poor country like India, Bangladesh, this third world country, this space infection becomes unnecessary. We don't go for extraction. We usually delay for money or your monetary condition. So then that in that case, the space, the different space that you all know, it is involved. And when the space is involved, it is very difficult. Sometimes it is so fatal, like Ludwig's angina can happen, and it is fatal that it is emergency situation, and you have to treat accordingly. So space infection, it is not possible to discuss all the spaces because the time factor. I am discussing very few space infection, and before that, I am talking few things of that, because this type of swelling, when it is a case where due to the accidental your injury of this front tooth, there is a periapical swelling has been developed, abscess has been developed, and it is the vestibular space infection. What is vestibular space? It is the vestibular mucosa and the surrounding muscles. It is the surrounding muscle is the orbicularis oris. So when this type of, so most of the beginners, most of the practitioners, those who have no idea how to drain a abscess, they usually rely on the antibiotics. But it is not like that. If you just simply if you go for this drainage of the abscess, you can easily drain the pus, and the patient will be within the 2 or 3 days. Patient will be all right. There will be no problem as such. You have not to give your strong antibiotics, your intravenous antibiotics, all these things. That's why I'm showing you. Now you see, this one thing is that this is the case of vestibular space infection in the lower teeth. Suppose a patient has come. I have seen so many cases. The patient in that lower 6, this is the lower 6, carious teeth, and you will find that the vestibular space, there is elevated vestibular area. And that is this fluctuation is present. And if fluctuation is present, definitely we have to think of that some fluid is present, and it is definitely abscess. So what you will do? Most of the I have seen that they usually give strong antibiotics by intravenous, and definitely some patients they go for quick response when you give the antibiotic, some don't. So if you give the antibiotic, what will happen? It will give the sterile abscess. Sterile abscess means this abscess, there will be no bacteria, but it will be, as gradually it will be resolved. But the problem is that there will be hard swelling that is called antibioma, because it is called the sterile abscess. There is no bacteria due to the antibiotics because you have already given prescribed and you have already given the antibiotics. There is no bacteria, but there will be hard swelling, and patient will complain to you after giving this injection, I am heart swelling, and it is not actually going off. It is still present for more than 1 month, because it will take more than 1 or 2 months to resolve this problem. So what is the solution? Solution is that simply with the help of the 11 number blade, what I do, I usually give some lignocaine with adrenaline here, so that this you can just separate the margin of the mucosa and the abscess, for the easy your, and now if you just push your this the blade, you can the pus will easily come out from this your abscess area, and it will be drained, and the patient will be the no pain. Patient from the very day, patient will he will tell you that don't have any pain and my problem is okay. So that's why vestibular space infection is just drainage is the first thing you have to do. Then if you think, then you can prescribe the antibiotic, but here antibiotic has got no role if you just believe on this simple your drainage of the abscess, which is the best thing, incision and drainage for the abscess. Now it is the case of Bacchus space infection. The patient came to our department. This swelling, you can see the huge fluctuant swelling, and the left side of this, it is a Bacchus space infection between the skin and buccal muscles. It is very easy to drain, and one principle of that drainage of the abscess is that you should not drain or you should not incise in that area. That means maximum fluctuant area, because if you do it, there will be ugly scar over the skin will develop. Because whenever this abscess will develop, you will find that this blood vessel will be under space. So the blood circulation is compromised in that area. So if you just give the incision over that area, definitely pus may come out, but after 10 days or 15 days, you will find there is ugly scar. So what is the best position or the best area where you have to give the incision in the healthy skin? And if you give the healthy skin and introduce your sinus forceps, and you can easily drain out the pus. So that is a very easy thing for the Bacchus space. That's why I am showing you. There is no need of any antibiotics for this type of patient. And you can see I am draining the pus with the help of this your sinus forceps. This is another case of submandibular space infection. You can see it is a submandibular space infection between the anterior belly of digastric and posterior belly of digastric. It is very easy to diagnose, and for further, I have just aspirated. Why I have aspirated? I have aspirated to know whether it is a simple any submandibular disease or it is the pus. And you can see the after aspiration, the pus is coming out. So there is no question of any other disease. Just simply I have to now I am ready for the drainage of the abscess, and here I have marked it with the help of your pen, and I just 1 centimeter below the mandible, because marginal mandibular nerve is there. If you don't do it, there is a chance of cutting the marginal injury of the mandibular. So that's why I have marked it as one breath below finger, one breath finger below the one breath finger, and you can see I have marked it 1 to 2 centimeters, and now it is, you can see I have given incision over that area, and you can see the platysma. You can easily find out this red area, it is a platysma, it has been exposed, because to go to the submandibular space, you have to expose this platysma, otherwise you cannot reach the submandibular space. And this is I have done introduced your sinus forceps, and you can see the pus is automatically coming out. And next thing I have done, I have introduced one your drain, plastic drain I have introduced, and I have kept it for 48 hours, so that any residual your pus, it will automatically come out through that area, and within after 48 hours to 72 hours, if there is no pus present or not coming out, then simply you can remove that drain. So this is another case of the submacetic space. The basic thing of the hallmark sign of the submacetic space is that patient cannot open, the trismus is there. And you can see this is the CT scan of the coronal CT scan, where you can find that this area, this black area, This black area means this is your ramus of the mandible, and this is your masseter. Within this area, this is the black area, and this radiolucid area is that where this pus is present. So in this case, when you are sure of from this CT scan that pus is present, you have to go for drainage of the abscess, and that you can go from outside. And nowadays, is a modified drainage of the abscess of the submaxillary space infection is there. Space abscess you can do, that is from intrally or also from externally. And we start from the intrally in the modified case, and we just introduce it outside. For the through and through drainage, all the pus, if it is present over there, it can come out. So this is all of the submaxillary space infection. Now I have only 3 or 4 your slides are left. I am about to end this our today's discussion. Now I am one important discussion about this antibiotic I want to do, because hazardous use of antibiotics, the irrational use of antibiotics is many. Most of us, whenever we get chance, suppose after extraction, even after any acute pulpitis, we use the antibiotic. But is it rational to use the antibiotic in a simple acute pulpitis? I think it is of no rationality to use the particular antibiotic in that case. So what are the principles? When should I use the antibiotic? That is the main discussion that I will do. Now you can see that in the balance, this machine, there is your host factor, such as this body's own defense mechanism is so strong that every day so many microorganisms are coming inside our body, and we can easily fight against them. That means we don't take antibiotics regularly. So, but if your body defense is low, your host defense is very low, then there is a chance of attacking so many diseases. It may be tuberculosis, it may be virus, it may be fungal, whatever it may be, it can attack you. So it depends on the virulence of the particular microorganism and the quantity, number. These 2 factors is different. But from this photograph you can see that it has a predominant role. This host factor has predominant roles than your virulence. It is the heavy than this virulence of the microbial factor. As because it is heavier, so it is also always maintaining balance. It is keeping us free from any disease. This host factor. So our host factor is so strong, even minor tooth extraction, even your any acute pulpitis, which is also infection, there is no need of any antibiotics, because the body immunity is so strong, it can easily combat this situation. But the problem is that if that virulence is maximum, your bacteria is virulent, quantity is maximum, what will it do? The maximum quantity is there. Definitely it will overtake this host factor, and they will take the predominant role than your host factor, and then the chance of infection will start. So suppose a patient with the oral cellulitis or the oral and microbial cellulitis has come, definitely some factors has taken predominant role. This may be virulent, your host factors is compromised. Your disease, some diseases are there, your physiological factors will not working. So there are so many factors are there by which the microbial factors are taking your predominant role. That's why these diseases have been produced. So what are those principles of antibiotic you have to know? First is the identification of the causative organism. You have to know whether it is a gram positive or whether it is a gram negative. By the culture test, you can easily know. So, or it is anaerobic one. You can easily know from this your culture test. Next is the determination of antibiotic sensitivity. But whenever the patient comes to us with this cellulitis or suppose any disease where there's a chance of spreading the infection more, then definitely you should go for the antibiotic. First, you have to start the antibiotic immediately. And that is called empirical. That is from the experience of the operator, which is used, or from the or any its own idea that it is a good antibiotic which is easily used, then it is called the empirical, and it is first you have to start. But empirical antibiotics would be narrow spectrum, like penicillin, we all know. But because it will take 3 to 4 days, your sensitivity test will come to your result. And within 3 to 4 days, if you don't start the antibiotic, there is a chance of spreading this disease. That's why antibiotic sensitivity is very, very important. So if from whenever the result will come, you can know whether gentamicin is sensitive, patient is sensitive to gentamicin, or the chloramphenicol, or any other antibiotics like macrolides, or your aminoglycosides is patient is sensitive, or penicillin not resistant to your this penicillin. So academically, you have to choose the particular antibiotic. Use of a specific narrow spectrum. We also start the narrow spectrum like penicillin, cephalosporin is a broad spectrum, but narrow spectrum antibiotic, penicillin, I think you should always start with the narrow spectrum antibiotic. Use of least toxic antibiotics. Least toxic antibiotics, no antibiotic is not like that without any toxicity. But it may be minor, it may be major. Like your gentamicin, it can cause your neurotoxicity, it can cause toxicity. So you should avoid if your amoxicillin is available or patient is sensitive to amoxicillin. Use of a bactericidal rather than a bacteriostatic. Bactericidal drugs like cephalosporin, your penicillin, this group of drugs is always preferred than the bacteriostatic like tetracycline and other drug which is bacteriostatic, which is not actually beneficial for the patient. Now is use of the antibiotic with a proven history of success. Suppose we have 4 antibiotics in our hand. It may be your aminoglycosides acid, it may be macrolides, it may be penicillin, it may be cephalosporin, or any other 4 group of drugs. But you have to remember the penicillin still now, I think worldwide penicillin is still now, in case of oral your maxillofacial, still now penicillin is widely used because of this proven efficacy, and it is the oldest drug. It was developed by the Alexander Fleming in 1929. So many days it has been also proved that it works well in our dental setup or dental your patient. That's why those drugs which are proven history of access should be always preferred. Encourage patient compliance means the number of drugs or the number of pills that patient is. If the patient is taking 1 drug in a day, patient it always prefers, because patient will never forget the 1 drug to take. But if it is 3 or 4 drugs in a day, most of the patient usually forget to take that, and that's why sometimes it may happen that disease is not cured so easily. So that's why patient compliance is another important factor that we should always maintain. Now, this cyst, we know cyst is, this is your dentarious cyst. We all know that this dentarious cyst, it is actually enveloping the crown of a tooth. You can see the enveloping the crown of a tooth, and this is the case where we have enucleated the case. This is a simple case of anteriorly the one canine is impacted, and surrounding your crown of the tooth, one cyst has been developed, and we have enucleated it. You can see that is the odontogenic keratosis. Another thing, odontogenic keratosis is always treated as there's a maximum chance of recurrence, because most of the patient after 2 or 3 or 5 years usually comes to us with recurrence rate. So that's why whenever if there is no chance of any maintenance of the continuity of the mandible, definitely you should always resect that mandible if it is less than 1 centimeter in case of odontogenic keratosis. So that is the odontogenic keratosis. And lastly, one is your enucleus periapical cyst. It is the anterior. You can see that we have Clearly, we have inoculated the cyst from the anterior, and this is the last slide I am going to discuss. I think it's for beginners. It is very important how to know the clinical, the signs of the oral, how to look like the oral cancer. Definitely, it is ulcerated lesion. Ulcer we all know, the breach of the epithelial, and it may be exophytic, it may be endophytic. I am showing you in the slide. It is irregular in shape, rolled out or everted margin, rapidly growing, indurated age. Now we look at this case. You can see this huge ulcerated margin. It has totally just make one large cavity just after necrosis, and you can see it has the everted margin, and this was after biopsy. It was we found that it is a case of squamous cell carcinoma, and it is a oral squamous cell carcinoma in the lateral border of the tongue. This lateral border of tongue of the oral squamous cell is very treacherous because and the survival rate is not good. Here you can see this is the central caseation or the necrosis, and the large your irregular border, everted margin, all are present here. It was also proved after incisional biopsy that it is a case of squamous carcinoma, and it is a exophytic growth of the your vestibular the buccal mucosa, lower buccal mucosa, and it is also a case of squamous carcinoma. So with that, I want to thank you all those who have really spent their valuable time listening. I don't know whether you are liked it or not, but it is I have tried my level best to give you the maximum your knowledge what I have gathered from my career. Thank you all.
Thank you very much, Dr. Subhashish Burman, for the nice and elaborate presentation. And now we'll go for our discussion session. Today we have expert panelists, and they will discuss on this topic, and they might have some questions to you.
Definitely.
Initially, I would like to request our panelist, promising maxillofacial surgeon and one of scholar in Bangladesh, Dr. Monjuri Mahamud, to discuss. And if he has any question, he can ask to you. Dr. Monjuri Mahamud.
Thank you very much. Am I audible?
Yeah.
Thank you very much, Dr. Subhashish Burman, for your nice and valuable presentation. And I think it has touched all the arena of oral and maxillofacial surgery, especially for the beginners. Beginning with the management of medically compromised patients, and with our daily tasks, that is day-to-day tasks of our maxillofacial unit, as well as our private chamber, that is impacted tooth removal, as well as cystic lesion management, management of oral cancers a little bit, and many more. And I would like to appreciate you to describe the management protocol for the patient taking oral antiplatelet drugs. And it is a misconception between many surgeons in our country also to stop the antiplatelet drugs before minor oral surgery or tooth extraction. And you have mentioned clearly that many journals have been published, and in many international protocols are there not to stop the antiplatelet drugs before simple dental procedures. And we are also following that. And you have also mentioned about the warfarin. I'd like to mention one more thing, especially during this pandemic. Many of our patients are taking rivaroxaban as an anticoagulant to treat COVID-19 infection. And sometimes some of the patients are on enoxaparin for a few days, and after that, they are continuing their rivaroxaban treatment for 1 month or so. So during this pandemic, we should also ask the patient regarding the history of taking rivaroxaban so that we can treat the patient easily. And I would like to request you to keep a light on rivaroxaban also. And I would like to thank you for your nice and valuable presentation. Thank you very much. And I would also like to thank our honorable chairperson of this session, Professor Ruhul Amin sir, and Professor Anupam Poddar sir for inviting me to attend this program. And thank you very much, Dr. Subhashish.
Yes, sir. Am I audible, sir?
Yes.
Yes, yes.
Yes.
Okay.
Yes, sir.
So first of all, you have already mentioned that whenever this type of anticoagulant drug patient is taking this pandemic situation, I have already told you that even what you have already told me that it is a bridge therapy that is used. Hello.
Yeah.
It is a bridge therapy that is used. Bridge therapy that means when the patient is taking this type of drugs, we usually should not stop it, but instead of that, we usually continue enoxaparin or low molecular weight heparin for few days, and on the day of surgery we stop the LMWH and we just go for surgery, and next day we again just continue with this same drug in this pandemic situation if the patient usually it is necessary for this particular patient to continue it. That is we usually follow in our hospital also. And regarding your this warfarin or any other drugs, that is the same protocol, because in case of simple extraction, I never stop this warfarin like drugs. I usually just simply put some this hemostatic agent, and I have already told you, and I also check the prothrombin time and INR definitely, because it is also very important for us to check before extraction. And that's all. I think you can easily manage this case by in this way.
Okay,
Thank you, sir.
thank you, sir.
Thank
Now, I am requesting our another panelist, Dr. Mohammad Amirul Islam. He is working for Metrosocial Surgery Department, TMSS Medical College Dental Unit. Dr. Mohammad Amirul Islam.
Thank you, sir. Am I audible?
Yeah, you are.
Okay, thank you. Thank you, Dr. Subhashish Burman. Very nice and elaborate presentation for the beginners. And as I am a teacher of the undergraduate students of the oral and maxillofacial surgery, I have few questions from myself. Firstly, what should we do if a root is displaced within the inferior alveolar canal? For a beginner, it is a complicated case because displacement of a tooth in the lingual pouch, it is too much difficult, and occasionally displaced within the maxillary sinus, it is too much difficult for them. But if they feel like a problem that the tooth is displaced within the inferior alveolar canal, what should we do? I am asking Dr. Subhash Burman in this case.
Am I audible, please?
Yes, sir.
Yes,
sir.
So I think I cannot understand your problem. That means inferior alveolar canal means it is in the lingual side or submandibular area, or the inferior alveolar canal itself.
Inferior alveolar canal itself.
So if it is if it is within the inferior alveolar canal, definitely you have to elevate the flap on the buccal side, definitely, and you have to remove some portions of bone, and you have to always check whether the inferior, and you have to find out the area of the inferior alveolar canal where this inferior alveolar nerve is going. And if you find that inferior alveolar canal, and I think there is no problem to find out the root also. But you have to always remember that if when you are extracting or removing a root during this procedure, if accidentally, if you penetrate or if you injure the inferior liver canal, that I have already told you in the paresthesia may develop. That is the thing that you have to remember. But inferior alveolar canal, I am frankly, I am confessing that there is no case happened in my case. But what I am telling you from my theoretical knowledge, that if it happens in that case, I will do like that. That from the buccal self, we will remove the portion of the bone, like what we do in the osteotomy of the jaw, this bilateral sagittal split osteotomy. Same procedure, but will not split, but we will remove the some portion of the bone. And if we find the root without damaging the inferior canal, you can easily remove that root. No problem will be there.
I have faced a case from my colleague that he was extracting a third molar teeth, and suddenly the tooth was fractured, and then the root was displaced within the inferior canal by inadvertently hitting the root. And next, we have tried.
So how did you remove it?
And we have removed it by removing the bone, but we are so careful about that the nerve or the vessels may be injured. There was a severe bleeding at a moment, but we have stopped by local hemostatic agent. Then we have tried, and we have extracted the root at last. But it was difficult for us. And after post-operative follow-up of the patient, there was a neuropraxia for the patient, and then we have followed the patient after 6 months. It was diminished the problem of the neuropraxia, but not completely till now.
Okay, so it is a nice case for presentation.
It was a critical case for us.
Okay, definitely.
And I have another questions from your presentation, sir. Would you please compare between painkillers that may be prescribed by our beginners of the oral and maxillofacial surgery in case of chronic renal failure patient? Comparison between painkillers in case of chronic renal failure patient. Which painkiller may be prescribed safely for the chronic renal failure patient?
In case of chronic renal failure patient, what I usually prescribe, that is definitely it is acetaminophen or paracetamol. But in some journal, it is noted that naproxen is another drug which is not so harmful for this renal patient. Naproxen, that is usually available in 500 milligram anapraxine, in the name of commercial name anapraxine, it is available. Naproxen, it is not so harmful. Even some cardiologists, they usually prescribe it also for the myocardial infarction patient, because it has been seen, the recent study, it is saying that myocardial infarction patient, the NSAID is totally contraindicated, but we still use it. Only the naproxen, that has some role to control the pain without any side effects of this myocardial infarction. And same thing is also for the renal patient. So if the acetaminophen or the paracetamol doesn't work, definitely I will stick on the naproxen.
Yes, thank you, sir. I have another question.
Yes,
do you
sir.
think any trimester is safe for tooth extraction if any emergency occurs in case of patient? Do you think any trimester is safe for extraction?
No, it is. I have already mentioned that
Yes,
it has been seen that there is no such contraindication for extraction of any tooth in any times. They are saying that if it is emergency procedure, definitely you can do, but you have to always remember that your dose of the lignocaine, it should be minimum, because lignocaine, it also crosses the placental barrier. It can also, though it is under category of B, but it has some effects on the fetus. So, but if possible, if you at all avoid that, it is always safe in the second trimester.
And another adjunctive question with this case, it is safe intraperiepical X-ray for this patient? pregnancy patient.
No, it is also said the intraoral periapical X-ray or where the dose is very, very minimum, which is not at all harmful for the fetus. But still, we don't prefer, because in this this our country, this poor country like Bangladesh or others, the patient don't believe it. Patient think that why I have done this. Suppose any problem arises, if anything happens, then patient will blame always the doctor that why you have done it. Because in all the cases there is X-ray is not done, but why you have done the X-ray? That's why we always try to keep safe. That's why we don't. I personally I don't use the interval, but it is clearly mentioned in the book and in the article or journal. The intraoral pedicure, where the dose is very, very minimum, there is no harm for the fetus or the mother.
Thank you, sir. Thank you for your nice and valuable answer.
Thank you.
Thank you, Dr. Mohammad Amirul Islam. I have a query to Dr. Subhashish Barman, sir. In regarding a CKD patient, what about tramadol hydrochloride, that means centrally acting analgesic, in case of CKD?
Hello.
Yeah, you are audible, sir.
Yeah.
In case
please
okay,
repeat the question. I didn't hear you.
Okay. In case of CKD patients, chronic kidney disease patient, what about tramadol hydrochloride as an analgesic drug?
Yeah.
For short duration.
Actually, tramadol hydrochloride is a synthetic morphine. So tramadol hydrochloride is I also use where the suppose patient is suffering from gastritis or whether it is contraindicated totally. Tramadol can be safely given, but it is my personal experience. I have seen that after prescribing tramadol, patient started nauseating or the vomiting. It is it is a common problem. But in the low dose, if you start with the low dose, and then if you don't cross the maximum dose, I think it is a safe drug and you can easily prescribe it without any damage to your gastric or the renal. Because we all know that the NSAID is usually is contraindicated for the renal patient as well as for the gastritis patient. It can damage also. So that's why tramadol is a very safe drug and it is also useful to control mild to moderate pain, but not the maximum pain that usually which is unbearable.
Okay, thank you, sir. I will come to you next time. And now I am going to our next panelist, Dr. Mohammad Nawazesh Ali Rajiv. He is my friend also, and he is a promising maxillofacial surgeon. And now he has been working in Bangabandhu Sheikh Mujib Medical University, only medical university in our country. I am requesting Dr. Nawazesh Ali Rajiv to say something.
Yes, sir.
Can you hear me?
Yes, sir.
So exactly, I had the same question with what Uday said. We can use tramadol safely. We had a study here in our university, and we also found it that tramadol is work great with TB patients. But just now you said it is not good for unbearable pain.
Yes.
So in unbearable pain, which analgesics you would like to suggest? As our experience says that paracetamol is also not good enough.
Can you give me some hints that which type of pain you are talking about? It is acute palpitis or it is after post-surgical? Which type of the origin of the pain?
So for example, acute palpitis.
Some technical problem.
Definitely, in case of acute palpitis, if this type of patient comes to me, I always prefer to go for the pulp extrapolation. No, I don't believe in any even your NSAID, even your diclofenac sodium or whatever it may be. Only pulp extrapolation is the best thing to do just to reduce the pain. There is no other option. But if you suggest after post-surgical, definitely what we do in our college, our is that we usually prescribe your your acetaminophen in liquid form, and as well as we usually prefer the steroids in the first or second day. After that, we usually omit the steroids. That is our protocol we follow in our college.
So another query I have regarding Cushing syndrome patients.
Yes.
So as they have already received a high amount of steroids.
Yes.
So in those cases, you showed us the Salim's protocol. So is it okay to use that much? Also, I mean, if we go through the books and journals, they're always suggesting that if you go for extraction with the Cushing syndrome patients, you have to add more steroids to reduce the stress. So, do you have any experience with this type of?
Yeah, I have seen one or two, not many, but I have seen one or two cases that usually, because it is a primary cause of this steroid. So in that case, this Cushing symptom, whenever it will patient comes to us, because patient usually the dose is higher for the very long period. Suppose if we have 10 years back, patient used to take only 40 milligram. Now patient is taking 100 or 120 milligram. In that case, as because already the adrenal suppression has been occurred, you have no choice unless and until if you go for this steroid supplement or the steroid cover. There is no other choice in the primary this Cushing syndrome. There is no other choice because you cannot reduce the dose of the steroid. Otherwise, there is chance of hypertension will develop.
So, last query regarding pregnant mother, we are frequently facing. They come with acute pulpitis, or and as you say that we try usually local anesthesia, rational use of only lidocaine, and then trying to extract the pulp. But a lot of beginners, I saw many cases that they used to use the pulp revitalizers, which were not basically safe, I think, for the pregnant mother. Do you have any comment on this?
Yeah, what I do whenever the pregnancy, I have seen a lot of pregnant mothers. I have already told you they are usually suffered a lot from the pain, toothache usually. Whenever the patient, this type of patient comes, previously I have used one or two cases with lignocaine for pulp extraction or the pulpectomy. But one or two cases I have seen that without any lignocaine, they can easily bear, because I have seen that this is really a great job they usually do. They can tolerate the maximum pain, because whenever we are extracting the pulp without any lignocaine, they can easily tolerate, because that's why when the normal your delivery is going on, they can easily tolerate this type of pain. And that's why I have seen that whenever I am doing the pulp extraction without any lignocaine, they can easily tolerate, and they have told me that if possible, I have no problem. You can continue your procedure. I have no problem, though they can bear a little bit of pain. But I have already told you that it is written that there is no harm if you use that little bit of lignocaine, but you should not cross the limit that is already mentioned for the lignocaine, because it is a category under BPA. It is theoretically correct, but in chamber but what you are saying about this pulp devitalizer, I don't know about. I have no idea about the pulp, whether it is causing any harm to the fetus or mother. I don't know.
Thank you, sir.
Thank you, Dr. Rajiv. I have another query in relation to this pregnant mother. Dr. Subhashish Barman, sir, do you have any experience? I think you have experience regarding analgesic, especially paracetamol with tramadol hydrochloride combination drug, which is have been using in our country, and we are prescribing it. Paracetamol plus tramadol hydrochloride.
Yeah. I also prefer the paracetamol with the tramadol, because I have already told when there is contraindication of the using of the NSAID in case of renal patient or in case of patient with suffering from gastritis or any other problems. Definitely, I also prefer the tramadol because it has no harm, because it's synthetic morphine, and as well as it controls the pain. But the problem is that after taking the tramadol, few patients has complained
nausea and vomiting.
Nausea and vomiting. That is the only problem they have complained to me. Otherwise, it is very safe, I think so.
Okay, thank you, sir. And now I am requesting our another panelist, Dr. Rezaul Islam, one of eminent maxillofacial surgeon in our country. Now he has been working in Dhaka Medical College, one of the tertiary level medical college hospital. You know it very well. I am requesting Dr. Rezaul Islam, please, please say some comment on this topic. Dr. Rezaul Islam. Reza bhai, can you hear me, Reza bhai?
Hello.
Hello, Reza bhai, can you hear me?
I think it has been disconnected, maybe.
Most probably. So now I am going to our next panelist, Dr. Habibul Hassan. He is the prominent maxillofacial surgeon in our country. He is working in Rajshahi Medical College dental unit. I am requesting Dr. Habibul Hassan Marshall bhai to say something.
Thank you, Mr. Moderator Uday Goswami. Thank you, Speaker Dr. Subhashish Barman, for nice presentation.
Welcome, sir.
Thank you. It was informative and very much useful to the younger dental surgeon, I think. And I would like to thanks to the man who was behind this, Dr. Anupam Poddar. He was once upon a time was met in the undergraduate level. And also, I would like to express my gratitude and thanks to other panelists, Mir Nawazis Ali, Mr. Dr. Amirul Islam Shaheen, Dr. Rezaul Karim, and finally, I would like to express my gratitude to our chairman and president of BAMOS, Professor Dr. M.D. Ruhul Amin sir. Actually, I enjoyed your lecture.
Thank you, sir.
Thank you. Actually, I have no such question, but just a comment. I think it is a very much time demanding and effective, useful topic to be discussed and learned by the younger dentist. Nowadays, actually, we are facing, we the people who are senior also, we also facing different type of problems during our routine dentistry practice. So this kind of discussion will not only make us courageous to do many things without any hesitation, especially for the younger dentist. Again, I will thank. I would like to thank Dr. Subhashish Barman and Dr. Uday Goswami. Thank you. Good night.
Yes, sir. I will always pay my gratitude to one and only Dr. Anupam Poddar because he has given me this opportunity. For that, I have got this time to say something in front of all these eminent person like you. So I also very happy to say something. And if all the younger dental surgeons they are benefited by this by my talk, I will
Yeah.
really very happy.
Okay. Thank you, sir. Am I audible?
Yes,
Yeah,
you
yeah.
are audible.
Okay, okay. Thank you very much.
And
Uh,
another thing is that I hope that this type of program will definitely help you to make the bonding stronger between these two countries. It is very
yeah, yeah,
helpful, not only for this. I am not going about any politics or something else. It is just for the younger people, for the younger generation, for the younger practitioners. That is definitely helpful because if we just don't give them knowledge, it is very difficult to nurture them. It is my idea that always we should feed them with the different type of knowledges that I have got from all of you. Thank you.
yeah, yeah. Professional improvement as well as for the betterment of the patient.
Yes, definitely,
Yeah,
sure.
definitely. Now, I would like to request our today's key person, our coordinator, Dr. Anupam Poddar, Associate Professor and Head Periodontology Department, Dhaka Dental College. I am requesting our
Can you hear me?
yeah,
Yeah.
sure.
Thank you, Dr. Uday Goswami, Assistant Professor, Department of Oral and Maxillofacial Surgery, Dhaka Medical College, for your wonderful introduction. Honorable Chairperson of today's webinar, Professor Dr. Mohammad Ruhul Amin, HOD, Department of Oral and Maxillofacial Surgery, Dhaka Medical College. Thank you, sir, for accepting to take chair. We are very grateful to you, sir. It is reality you are a well-known clinician and academician and performs a good job in Dhaka Medical College. You are also a president of Bangladesh Association of Oral and Maxillofacial Surgery. And Dr. Subhashish Barman, Associate Professor, Department of Oral and Maxillofacial Surgery in R. Ahmed Dental College and Bardhaman Dental College, is the speaker of today's webinar. We are very much grateful to him. He is very busy clinician as well as academician. Dear Subhashish Barman sir, your today's webinar is very nice and informative presentation that will be helpful for our general dentistry. Now I grateful to our knowledgeable panelists. They are all are well-known maxillofacial surgeons worked at different part of in our country. Dr. Habibul Hassan Marshal in work in Dhaka Rajshahi Medical College Dental Unit. Dr. Mohammad Rizaul Islam worked in Dhaka Medical College. Dr. Min Nawadesh Ali Rajiv worked in Bangabandhu Sheikh Mujib Medical University. Is only one medical university in Bangladesh. Dr. Aminul Islam Shahin worked in TMS Medical College Dental Unit, and Dr. Munjura Mahmood worked in Chittagong Medical College Dental Unit. I am also thanks to Mr. Moniruddin Pintu, who worked as a regional marketing manager, ACI Pharmaceuticals Limited, who cooperated us every time, including this program. And also thanks to Dr. Mahi of ACI Pharmaceuticals Technical Division, who is very much cooperative, and also thanks to Raj TV for broadcasting. Thank you all. Thank you, Subhashish Barman sir, for your nice and informative presentation. I hope this presentation is helpful to our general dentist, and it is also also helpful to our beginner who try to work in oral and maxillofacial surgery. Thank you all.
Good night and thank you. Welcome. Hope again I will meet with you again, and I will, if you get the opportunity again, I will talk with another topic. Thank you.
Okay, thank you very much. We are at the end of this webinar. Before going to the chairperson's speech and conclusive session, I would like to invite our scientific partner, from ACI Pharmaceuticals Limited, Mr. Monirujjaman Pintu. So to say a few words. Regional Marketing Manager, Mr. Monirujjaman Pintu.
Sir, thank you very much. Thank you very much for giving us opportunity. Sir, আমাকে শুনতে পাচ্ছেন স্যার?
Yeah.
Yes. Sir, thank you very much for giving us the opportunity. Actually, অনুপম পোদ্দার স্যার আমার খুবই পছন্দের একজন ডক্টর। স্যারের সাথে অনেকদিন ধরেই আমাদের জানাশোনা বা পরিচয়টা স্যার আছে। তো স্যার সেই ক্ষেত্রে স্যারও আমাদেরকে বিভিন্ন সময় এই ধরনের প্রোগ্রামগুলো করার ব্যাপারে স্যার উনি ইন্সপায়ার করেছেন। So I am very much grateful to Associate Professor Dr. Anupam Poddar sir. Also Habibul Hasan sir ke dekhlam, Nawazer sir ke onek din por dekhlam, Ruhul Amin sir ke dekhlam, khub bhalo laglo sir. Thank you very much sir. Next আপনাদের এই প্রোগ্রামগুলোর জন্য ডেফিনেটলি আমরা স্যার পার্টিসিপেট করব এবং আমাদের এই যে অপরচুনিটি দেওয়ার জন্য স্যার আপনাদেরকে ধন্যবাদ। Thank you very much. Thank you sir.
Okay, thank you very much. Now I'm going to, and I'm requesting our today's SCR person, Professor Dr. Ruhul Amin sir, Head and Chairman of Oral and Maxillofacial Surgery Department, Dhaka Medical College, to conclude this session as well as to give thanks our today's speaker, Dr. Subhashish Barman sir. Now, Professor Ruhul Amin sir.
Thank you, Uday. It has been momentous today. Today we have discussed, shared, and learned about the evidence and responses needed to achieve better intelligence of oral surgical procedure for beginners. This is a time-bending topics in our country. I would therefore like to congratulate all of you so such a successful event and such fruitful discussion. Thank you, Professor Dr. Subhashish Barman, for your speech. It was very informative. We have got many new ideas from your speech. I sincerely acknowledge and thankful to co-moderator Dr. Anupam Poddar, Associate Professor, Dhaka Dental College, for communication with renowned maxillofacial surgeon Dr. Subhashish Barman. A special thanks goes to ACI Pharmaceutical for their assistance and sponsorship this webinar to arrange. I would like to express my appreciation to the speaker, moderator, colleagues, ladies and gentlemen. I thank you again for your support and I congratulate you on the success of today's live webinar series. I look forward to continue to work with all of you to help build a more secure and prosperous future. Thank you very much. Thank you all. Thank you, Dr. Professor, our guest, the international speaker. Thank you again.
Thank you, sir. We are at the end of this session and good night to all. আর সর্বশেষ আমাদের ডক্টর সুভাষিস বর্মন স্যারকে বলি, যেহেতু আমরা বাঙালি, একটু বাংলাই বলি, যে আমরা মাঝে মাঝেই এরকম সেমিনার করতে চাই এবং যেহেতু উনি আমাদের সময় দিয়েছেন, আমরা আশা করি ভবিষ্যতেও আমরা আমাদের মাঝে ওনাকে পাবো, এভাবে আমাদের নলেজটাকে শেয়ার করতে পারবো। এক দেশের সাথে আরেক দেশের নলেজ, এক সোসাইটির সাথে আরেক দেশের আরেক সোসাইটির নলেজ শেয়ারিংটা খুব ভালো হবে। সুভাষিস স্যার, আপনার মাইক্রোফোনটা আনমিউট করে নিতে হবে। মাইক্রোফোনটা আনমিউট করে নিতে হবে।
আমি একটা কথাই বলি, আমি যখন 2015-এ মার্শাল সাথে যখন আমি ওখানে কথা বলেছিলাম, আমি কিন্তু বাংলাদেশের সম্বন্ধে আমার আইডিয়া একটা বিশাল। আপনারা হয়তো ভাববেন যে আমি রাত্রিবেলা হয়তো আপনার সামনে বলতে হয় বলে, না, আমি সবাইকে বলি, আমার স্টুডেন্টদের বলি, আমার আইডিয়া ফর দ্য বাংলাদেশ maxillofacial surgeon, it is really a high, মানে আমার তাদের রেসপেক্ট ফর দ্য ব্যান্ড বাংলাদেশ, because I have seen that the way they are working in Bangladesh, it is really havoc. I am really thankful to all those because I have seen in my own eyes. আমি নিজের চোখে দেখেছি, সেই জন্যই আমার খুব ভালো লেগেছে যে আপনারা অনেক ভালো কাজ করছেন। এই যে এই যে নলেজের যে শেয়ারিং এটাও খুব দরকার। আশা করি আমি আবার যদি আমাকে সুযোগ দেওয়া হয় নিশ্চয়ই আমি আবার বলবো।
থ্যাংক ইউ স্যার। আর করোনা পার হয়ে গেলে আমরা ফিজিক্যাল সেমিনার হবে আর কি, করোনা কালটা চলে গেলে। আমরা
ডক্টর পোদ্দার আছে তো।
আমরা এটা প্রার্থনা করি। আর আমাদের যেহেতু মার্শাল ভাই, যেহেতু আমাদের বামুসের প্রেসিডেন্ট এখানে আছেন, আমাদের রুহুল আমিন স্যার এখানে আছেন, আমাদের বাংলাদেশ ম্যাগনিফিসেন্ট সার্জারি সোসাইটির উনি প্রেসিডেন্ট। তো স্যারের সরাসরি নির্দেশনায় এবং স্যারের তত্ত্বাবধানে আমরা ফিজিক্যাল প্রোগ্রামিং করব খুব রিসেন্টলি, করোনাটা পার হয়ে গেলে।
নিশ্চয়ই আমিও যাই।
2015 সালে সুভাষিস বর্মনের সাথে আমার পরিচয়। সেই আমাদের ঢাকা ডেন্টাল কলেজের একটা প্রোগ্রামে উনি এসেছিলেন, এন্ড হি ওয়াজ ইমপ্রেসড। আমাদের এখানকার কাজ দেখে উনি খুশি হয়েছিলেন। আমার সাথে সময় অনেকটুকু সময় ওনার সাথে আমি পার করেছিলাম। তো দ্যাট টাইম তার সাথে একটা বন্ধুত্ব হয়ে গিয়েছিল। তারপরে তো বন্ধুত্ব চলছে, কিন্তু আজকে এখন অব্দি আছে। কিন্তু আজকে ডক্টর বর্মনের প্রেজেন্টেশন দেখে আমি মুগ্ধ হয়েছি। আসলেই মানে আমাদের জুনিয়র ডেন্টিস্টদের জন্য খুবই সময় উপযোগী, টাইম ডিমান্ডিং একটা বিষয় নিয়ে উনি বললেন, কাজে লাগবে। এবং ডেফিনেটলি আমরা যারা সিনিয়র
মানে ইনফরমেশন যত
জি 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 বলেন।
হ্যাঁ, আপনাদের কাছে এই যে ফিডব্যাক গুলো পাচ্ছি, এগুলো আমাকে আরো হেল্প করে যে অন্য যে ইনফরমেশন গুলোকে কালেক্ট করার জন্য। হ্যাঁ, সেই জন্য এগুলো খুব দরকার আছে।
নলেজ এক্সচেঞ্জ শেয়ারিং এর জন্য এটা তো আসলে এই প্ল্যাটফর্মটা খারাপ না। আমরা এইভাবে যে কথা বলছি, তো এটা খুব ভালো। মনে করে এই ধারা অব্যাহত থাক। এবং এর পেছনে যারা কাজ করছিল, বিশেষ করে অনুপম পোদ্দার, ওই মূলত এইটার মানে আসলে কি পারসন বিহাইন্ড দ্য স্ক্রিন। তো সেই এটাও করেছিল। এবং আমাদের যে প্রফেসর রুহুল আমিন স্যার, উনিও এই কাজটাকে উৎসাহ বাস্তবতার মানে আলোর মুখ দেখেছে। এজন্য আসলে আমরা তাদের কাছে গ্রেটফুল। তো আজকে মডারেটর উপস্থাপক উদয় গোস্বামী সফলভাবে উপস্থাপনার মাধ্যমে এই একটা সাকসেসফুল প্রোগ্রাম করলো। আসলে এটা উই আর হ্যাপি, খুবই মানে আমাদের ভালো লাগছে। এবং আমরা ডক্টর বর্মনকে এরপরেও আরো আমাদের অন্যান্য প্রোগ্রামে আশা করছি পাবো, এবং তার সাথে আমরা আবার যোগাযোগ করে আমরা হয়তো তার সাথে আবার আমাদের দেখা হবে, কথা হবে, এরকম ওয়েবিনারে অথবা ফিজিক্যালি। তো আমরা সেই দিনের খুব শীঘ্রই হয়তো আমাদের দেখা হবে আর কি।
তো স্যার, চেয়ারপারসনের অনুমতি ক্রমে সবাইকে শুভরাত্রি জানিয়ে এখনই শেষ করি।
ওকে, গুড নাইট, শুভরাত্রি।
ধন্যবাদ স্যার, নমস্কার স্যার, সুভাষিস স্যার, দেখা হবে আবার, কথা হবে। ভালো থাকবেন
স্যার। গুড নাইট।
আপনারা ভালো থাকবেন, আপনারা ভালো থাকবেন, সবাই সাবধানে থাকবেন, ভালো থাকবেন।
করোনা সবার জন্য কল্যাণ ভাইয়া।
হ্যাঁ, আমরা ঘরের মধ্যে আমরা ডিসকাস করছি।
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.